Okay, so here we are now going to talk about the various types of cervical traction and when and why and how we would use traction in the cervical spine. So when we look at our treatment parameters, the variables have to be consistent with the treatment goals needed to resolve the patient's disability. So you need to think about your patient position, the angle of pull, and the amount of tension that you want to apply. So if you need to review what those kind of terms are, look back at the first couple videos, as well as there is that chart in the second video that goes through positioning and so on for angle to pull and the type of sustained or intermittent compression that you might or traction that you might need. Okay, so with cervical traction, we have two types. We have manual traction and we have mechanical traction. And so when you finish watching this video, next day in class, we will actually go over how to perform each of these, but I want you to have the background already. So manual traction is usually what we start with in the cervical spine. Because we control the amount of pressure and the amount of pull, it's kind of an easier transition for our patient. And so we apply it usually before we'd ever go and try mechanical traction. So we have our patient lying supine. That's preferred over sitting because it eliminates the effect of gravity, right? If you're seated, gravity is pulling the head down, the spine musculature is contracted around the neck. So supine is the best. It increases the relaxation of the patient, decreases muscle guarding. You want to make sure throughout this whole process you keep asking your patient if they have any sort of discomfort. If any of their symptoms increase, we stop the treatment. If our hand placement is bothering them, we adjust our hand placement. You just want to make sure that they don't get dizzy or anything like that too. You know, think about your contraindications as well before we apply this. So we have them supine. We cradle the head in our hands, or we can use a towel or a belt. So I'll demonstrate that in class. But basically you kind of grip usually around the occiput. You can also do the other hand either under the chin. We can have both hands at the occiput. We can have one on the forehead and the occiput. The towel can go around the occiput. So we have multiple options. So we'll see the different options in class, as well as there's a video showing some of the different options out there as well. So we usually begin gentle, only about 10 to 15 pounds of force. Now, it is almost impossible to know exactly how much force you're applying manually. You know, pretty much max that we're able to do in the spine is going to be around our 25 pounds. So if you kind of do half of what you think your kind of full pull would be, that's probably kind of where our gentle position is. We can also position the head to target different parts of the cervical spine. So in more of a neutral position, we tend to target more of the upper cervical, so like C1 through about C4. And then if we put them into more of a flexed position, about 25 to 30 degrees, we'll target more of the lower cervical. We can also put them into some lateral flexion, so kind of ear towards shoulder, and that will relieve the pressure on the spinal nerve on the side that's opening, so away from the ear that's going towards the shoulder. So that can sometimes help, especially if they're having that pain radiating into their arms. And typically we do an intermittent, about 30 seconds on, 10 seconds off for our manual treatment. For most pathologies, that separation for the cervical spine will begin to occur when we get about, again, that 25 pounds of force. Some sources go all the way up to about 20% of the body weight if the person is laying down. And then, again, it's just going to kind of depend on our system. So again, to open the cervical spine, especially the lower cervical spine, about 25 to 30 degrees of flexion is helpful. If we're trying to separate the facet joint surfaces, we can have about 15 degrees of flexion. That's usually the point for the facet joints versus the intervertebral space where you need about 25 to 30 degrees. If you're doing seated, kind of a leaning position, then we usually also get more increase, but then we are fighting gravity as well. So we usually don't want to do the cervical traction in a seated position if we can all avoid it. So when we look at our mechanical, So this can be done with a machine. We actually have one that uses an air pump to set up our traction. So there's lots of different types of mechanical traction that you could experience. They almost always have some sort of harness, so either a mandibular occipital harness, so it goes around the back of the head and around the chin, or sometimes you have ones that just go around the occipital and then usually a strap across the forehead. So it just kind of depends on your machine. So again, there's some videos showing some different varieties of positioning. But that harness cradles the patient's head, and the pulley system is set up to adjust for the tension. So again, ours, we use a pump to create that, but on the machines, it would be a pulley system with a motor. With the mechanicals, we can do intermittent or sustained. So we could do like our 30 seconds on, 10 seconds off kind of situation, or we could just set it and treat. And that could be anywhere from 5 minutes up to potentially 45 minutes, depending on the treatment that they would need. So this would be what a typical cervical traction unit looks like. So again, there's the harness that we would strap them in. We would do all of our settings on the machine here. This pulley system and kind of the straps of the friction of the table is what stabilizes them, and then the traction would go through the machine. This also just then again breaks down kind of the description, your indications, why you would use cervical traction, the primary effects we're going for, the durations. So again, facet joint pathology, usually about 25 minutes. Degenerative disc disease, maybe only about a 10-minute treatment. Disc protrusions are about 8 to 10. Muscle spasms, maybe 20 minutes. We can do, again, the sustained or the intermittent. Different conditions benefit from different doses as far as intermittent or sustained. Our contraindications, you want to make sure you rule all of these out, and then some of our precautions. So again, we almost always do a manual traction first before we would attach someone to a traction machine. You need to monitor them throughout. We need to make sure that no other pain is being increased. Low tension should be used. If there's any hypermobility, we usually just say hypermobility would be a reason to not do traction. Sustained or continuous traction should be monitored, and if motion is contraindicated, so if we wouldn't want that motion, we would maybe do more of a sustained. We don't do really continuous, which is for hours at a time at all. And then you want to make sure that the harnesses are comfortable for them. So especially if you're doing those mandibular occipital harnesses where it goes around the jaw, that can sometimes increase tension in the temporomandible joint, the TMJ, and that could be problematic. So you wouldn't want to use that if that creates any pain for them. Again, just kind of looking at some of the pathologies and the angles that you potentially want. So again, the facet joints, usually a little more flexion, at least about 15 degrees of flexion, and we usually do more intermittent traction. The intervertebral space for degenerative disc disease, so to kind of create more space in there. Again, usually cervical flexion. If we go too much though, we can have some problems. Lumbar is a little more neutral. That's more ideally a sustained situation where we could hold it. So ideally that would be more of a mechanical versus using manual for that. Nerve root impingement, usually you do, if it's pain on both sides, we do more neutral. If it's a single side, then we do, we rotate or laterally flex the spine to the opposite side. And again, sustained usually is more beneficial, but we can also see some effects with the intermittent. But with longer on times in that intermittent. So if we can hold for a minute or 2 minutes and then have shorter off times, that would be ideal. And then disc protrusions does best with intermittent, where we can get a little bit of that pumping kind of action. So extension, neutral, or flexion based on whatever relieves their pain. And so if they feel better in a little more of a flexed position, we would put them in a flexed position, extension or neutral, depending on what affects their pain. And then finally, with our muscle spasms, we're trying to find what other position will actually elongate those tissues. So if it's on both sides of the spine, we usually keep the spine more neutral. If it's on a single side, then we can do a little bit more of that side flexion or potentially some rotation or things like that. And ideally, that's usually also more of a sustained, more like as if you were going to stretch those muscles, because that's really what you're trying to do. So cervical traction's effect on the injury response. It reduces the pressure on the cervical nerve roots. So research has shown that. That causes the mechanical pressure from the bony protuberances or those intervertebral disc protrusions. We can elongate the cervical spine to separate the vertebrae and decompress those structures. There is a clinical prediction rule, which helps you understand if cervical traction is potentially beneficial with potentially exercise. So those who are more likely to benefit from cervical traction and exercise together. So patients who demonstrate 3 of these findings increase their positive outcomes to about 79%. 4 of those findings, that jumps to about 95%. So if they're aged 55 or older, if they have peripheralization of their symptoms with mobilizations of C4, C7 vertebrae. So if we were to do glides on the C4, 5, 6, 7 vertebrae, if that sends symptoms into their extremity, into their arm, that would be a sign that they might benefit from the traction here. Positive shoulder abduction test, again, increasing their symptoms in that arm. Positive upper extremity nerve tension tests, again, sending sensation, and positive cervical distraction test. You'll learn more of those, the cervical distraction test, especially when you get to spine next semester. But basically, you know, if we apply traction, does that reduce their symptoms is essentially an answer. And so if that answer is yes, then yeah, traction might help for this person. So again, traction could help for other situations too. This is just one based on research that has shown benefits. Other effects on the injury response process, muscle spasms, so reduce the pressure on the cervical nerve roots, stretches the muscle, so both of those reasons would help reduce muscle spasms, and that interrupts the pain spasm cycle. If we reduce the cervical muscle spasms, it's usually best once we find that optimal amount of traction. So the first treatment, they might not get the results that we would expect, because we need to add a little bit of distraction, of tension, or we maybe need less. So it's a little bit of trial and error to really get the optimal amount for this particular patient. And also the positioning of the body plays a big role in that too. Are we really targeting that muscle that's in spasm? Pain, we decrease the amount of mechanical pressure that's on the cervical nerve roots, that's on the facet joint structures. All of that is going to help with pain. Intermittent traction, some other things that research has shown to help with pain. It improves blood flow and decreases myofascial adhesions, which both those things help with pain. It stimulates joint and muscular sensory nerves, inhibits the transmission of pain through gate mechanisms. So we get that A beta fiber activation from the stretching, from even the sensation within our hands of being on the person. We get some of that gate mechanism and affect pain in that manner.